This video is available in 21 languages. यह वीडियो 21 भाषाओं में उपलब्ध है. To change the audio, go to settings, click on the audio track and choose your favorite language. ऑडियो बदलने के लिए सेटिंग में जाएं, ऑडियो ट्रैक पर क्लिक करें और अपनी पसंदीदा भाषा चुनें.
Bipedal locomotion requires a contradictory piece of engineering. The hip must support extreme axial loads while preserving a wide range of motion in several planes. During a standard walking gait, the hip joint routinely absorbs contact forces equal to 3 times the total body weight. Unexpected movements, such as a simple stumble, send kinetic spikes of up to 8 times body weight directly through the femoral head. Forces of this magnitude transform conditions like end-stage osteoarthritis and femoroacetabular impingement into predictable mechanical failures. These failures originate from millimetre-scale deviations in the bone's geometry and the structural elasticity of the surrounding joint capsule. To understand these breakdowns, we will reconstruct the hip from its skeletal architecture to its soft tissue constraints, and then calculate the dynamic forces acting on the system. Every millimeter of structural alignment dictates the joint's eventual fate. Understanding hip pathology requires evaluating the joint as an integrated biomechanical system. This model shows a healthy hip's articulation, with cartilage covering most of the femoral head. Normally, the femoral neck shaft angle is 125 degrees, providing pelvic clearance. Angles exceeding 130 degrees cause Coxa Valga. Less than 120 causes Coxa Vara. This angle is not static. It starts at 150 degrees at birth, deusing through adulthood as bone remodels under weight-bearing stress. Beyond its vertical angle, the femoral neck rotates anteriorly. This medial rotation, between 15 and 20 degrees, is femoral anteversion. Abnormalities at this junction cause femoroacetabular impingement. Cam-type impingement occurs when a bony prominence at the head-neck junction causes a mechanical collision during movement. Conversely, pincer-type impingement involves acetabular overcoverage, where excess bone pinches the femoral neck during flexion. These structural deviations alter the abductor muscle lever arms, creating mechanical conditions for inevitable joint failure. The hard bony structures are supported by a strong ligamentous capsule that ensures hip stability. The strongest of these ligaments is the iliofemoral ligament, located on the hip's anterior aspect. This micro-CT thickness map shows the density distribution of the capsule's proximal attachment at the anterior-inferior iliac spine. A histological section reveals the underlying bone thickening in response to high tensile stress generated here. With a tensile strength greater than 350 newtons, the iliofemoral ligament limits adduction and prevents the pelvis from tilting posteriorly during upright stance. This ligament plays a critical role in bipedal locomotion by facilitating passive energy storage and return. At intermediate walking speeds, this elastic transfer handles up to 70% of the energy required, leaving just 30% to be actively supplied by muscles. The anterior capsule functions as a specialized dynamic spring. Structural damage to this tissue increases the metabolic cost of walking and destabilizes the joint. To understand how geometry and tissue interact, we must analyze dynamic loading of a single-leg stance. The hip functions as a fulcrum. The body's weight exerts a downward force operating on a long lever arm extending to the center of gravity. This is offset by an upward abductor muscle force acting on a much shorter moment arm. Because the abductor lever arm is so short, these muscles must exert a force multiple times the body weight to keep the pelvis level. Variations like Coxa Valga, short femoral necks, or a wide pelvis increase this lever arm ratio. This increases the required abductor force, multiplying total joint reaction force and crushing the femoral head into the acetabulum. This mathematical lever ratio, rather than raw body weight alone, multiplies forces to destructive levels and accelerates the progression of osteoarthritis. When these reaction forces become painful, or the muscles too weak to support the load, the body adopts a compensatory strategy. This manifestation of muscle weakness and joint pain is known as the Trendelenburg gait. To reduce the joint load, the patient leans their torso over the affected hip. This lateral shift moves the center of gravity closer to the femoral head to shorten the body weight moment arm. While this reduces the force required from the abductors, it is an inefficient means of ambulation that significantly increases the energy required to walk. clinicians can achieve a similar reduction in joint action force through the use of a cane in the opposite hand. The cane produces an upward moment that assists the abductor muscles. This reduces the mechanical demand placed on the joint itself. A cane used in the opposite hand can reduce the total compressive joint reaction force by as much as 50%. Beyond these supports, manual therapy and physical therapy interventions target the soft tissue constraints. Long-axis traction attempts to relieve pathological contact forces by restoring the loose-packed position of the joint capsule, specifically addressing the tension in the iliofemoral ligament. Surgical interventions like capsulotomies or Gans osteotomies ultimately aim to accomplish the same structural goal, resetting the joint's geometric calculations. Clinical resolution of hip pathology depends on this unified perspective. Static levers, capsular energy storage, and dynamic force ratios are inextricably linked in the maintenance of joint health.